time I'm pushing the material inside, so that I avoid the membrane to fall inside the sinus without control. Then I'm placing autogenous bone in this gap in the crestal area. So in the crestal area, which is the much critical area, just autogenous bone. In the sinus, we have bovine bone. And I'm going to fill all the gaps in this area because we are not in a GBR scenario. We are in an autogenous bone augmentation, and empty spaces are not necessarily filled by new bone formation. So I need to bring the inductive factors all around, also because no membrane will be placed. It means that the soft tissue will line directly over the graft material, and the inductive factor needs to be well distributed and present all around, three-dimensionally, all around the defect area. So, and all this particulated material, remember, is coming from the original block. So no other area has been scraped except for the lateral window of the sinus, which is a minimal amount of bone, has been collected in that area, but the 98% of this material is coming from the original 3.54 millimeters cortical block thickness. So all this, you see, you can appreciate how much bone have been collected and have been obtained by the Curie's management of the block. So we are filling all the gaps. You see that we have nice coagulum distribution here. We have mechanical stability given by the bone lamina. We have the inductive factor. So basically we are rebuilding back the bioreactor has been described before during the extraoral management. So everything is look very, very nice, and we need, obviously, as I told you, to fill all the gaps. And once we have filled all the gaps, we need obviously to place a collagen membrane over the window sinus to avoid the material to coming out and to separate that area which is based on xenograft from the soft tissue. This is very important because they are not working as autogenous bones. So there is a big, very big discrepancy between the quality and property of the two grafting materials. Now, once we have placed all the particulated material, we can place the occlusal block working with the screws. Remember that we have already the two holes, and to do this we are going to redefine the position, or to find back the position of the occlusal block. We are going to work with the probe, perioprobe, to find back the holes on the recipient side and to align the block to the old, to the previous performed holes. So you see here the periodontal probe, we bring back the occlusal block, and with the periodontal probe we are going to find out the original site, the original entrance, performed ends of the screw. Once we have find the direction, we take the screw holder and the screw, the osteosynthesis screw, and we are fixing distally, first the block and then mesially. Once again, the primary stability need to be achieved, otherwise excessive instability, also in terms of strain, has a negative impact on the bone formation. So you can work also with autogenous bone, but the risk is to have a non-osteointegration, but a fiber integration of the site. So this is at the end of the surgery. We have a nice three-dimensional bone reconstruction, horizontal and vertically. We have pure autogenous bone on the crestal level. We have bovine bone on the sinus. So we rebuilt vertically and horizontally the crest. You see here from an occlusal point of view how nice is the bone augmentation, and obviously everything follows the anatomical contour. So we are aligned to the tuberosity on the distal area, and we are aligned to the canine on the mesial area. Now you see once again that the palatal flap is perfectly aligned to the site, and now we are closing the wound. We are first performing a sutures on the mesial aspect of the flap to align mesiodistally the flap, And we do this to avoid to have a distal displacement of the flap. So the first suture is always on the mesial side. And then we can take care of the crestal incision. But just once we have aligned mesiodistally the flap. That is very important because if you concentrate yourself immediately in this area, you can have a distal displacement of the flap, and then you have big difficulties on placing without tension the flap aligned to the mesial incision. So, and before closing the wound with the horizontal master suture, we are placing breaking force suture. Breaking force sutures are sutures which has a dramatic role in reducing the tension of the flap, because they are able, in accordance to a paper we have published, me and gjhdtiut in 2014 in JOMI, is able to reduce till 87% of the residual tension. So it means that our flap will be really passive. Passive in accordance with those criteria described by by Burkhardt and Lang in 2010 in Clinical Olympia Research, where they describe that the really passive flap that has a high percentage in primary wound healing is a flap where the tension of the sutures is around 5 grams or below than 5 grams. It means that the flap has their final position, the flaps should have their final position without the needs of the sutures, which is tremendous difficult in some cases, and these breaking force sutures are bringing the tissue in that position without generating ischemic effect as the horizontal matrix suture usually are doing. How is done? We are going on the palatal side. You saw already on the video. We go on the palatal side 7 to 10 millimeters from this point. And then we are going to engage just the periosteum on the coronal incision of the periosteum releasing incision. This is the periosteum border of the released periosteum. So we are not involving all the thickness of the tissue, so we don't involving the vascularity of the buccal tissue. And then we go back 7 to 10 millimeters apically to the rim of the flap, but 5 millimeters more distal or mesial compared to the entrance point. And now when we are pulling this suture, when we are tightening this suture, look what happened on the vestibular flap. This flap is moving coronally and towards the palatal flap, having a fixed final position that is not generating any ischemic effect due to the fact that we are involving just the periosteum in this layer and not the full thickness flap, but the flap has a completely different position. We are going to place this suture, one suture every 2 teeth. So in this case, in this sextant, 2 sutures are needed to define the final position of the vestibular flap. So we see the effect of the first one. We are doing the second one in the same way. So engaging just the periosteum on the vestibular side. And then we go back on the palatal side, 5 millimeters more distal compared to the entrance point. Once again, when we are pulling this, when we are tightening this suture, you're going to see that the final position of the flap is basically in a perfect position, because we have a fantastic tension-free position of the buccal flap. You see that the 2 flaps now are basically together. There is no suture sealing the wound. Obviously, we have the breaking force suture in position, but we have no ischemic effect on the buccal flap. This is the very important point. And now we have no tension here. We have a maximum passivation of the flap here. We have 0 tension. It means that when we are placing our horizontal matrix suture that can generate an ischemic effect, this suture will work for 1, 2, 3 grams, which is a minimal amount. Now, before placing the typical horizontal matrix suture, we are going to place a vertical matrix suture on the distal aspect of the canine. This is going to generate a nice seal of the tissue in that area. So we are going inside in the apical area, coming out on the base of the papilla in the apical area, and then we go back from the palatal side in the top of the papilla. Now we can engage back on the palatal side. So we are going to have a double effect of this suture. We have a sealing in the deep, and we have a compression also on the top. This avoids us the need to place